everyone, and we might start to allow time for today's session, but welcome to the third session of the Menzies Youth Type 2 Diabetes webinar series. And I'd like to start by acknowledging the traditional custodians of the lands on which we stand. In Darwin, that's the Larrakia people, but I extend that respect to the traditional owners and leaders of the many lands on which our viewers are dialing in from, and pay our respects to elders past, present and emerging. And I'd also like to acknowledge the important role that Aboriginal and Torres Strait Islander people play here at Menzies and in this project. In terms of logistics, we have an hour for the webinar. We have Dr. Emily Papademos, who's a paediatric endocrinologist at the Queensland Children's Hospital, and also is a key lead of youth type 2 diabetes work in Queensland, presenting on screening and management of type 2 diabetes in the paediatric age group. And she'll start with a 20 to 30 minute presentation. And then after the presentation, we have open time for discussion with Raymond Anderson and Emily. Raymond is an Aboriginal health practitioner in Borroloola who does a lot of work in chronic disease and is an emerging leader in Borroloola. You'll see that there's a capability for you to add questions into the question and answer box, and we encourage you to do so. Due to the number of people that on the webinar, we may not have time for all the questions. And so we will try to prioritise the questions by the most popular as voted by the audience. So you also have the capability to upvote the questions so that they do get answered. And we'll also have a quick note to see if there are questions that may be answered in future webinar sessions, and we'll mention those if that's so. And there will also, at the end, be an option for a case study discussion. This won't be recorded, only the presentation and the discussion will be recorded for later viewing. And so I'll hand it over now to Emily. Thanks very much.
Thanks, Angela. Hopefully this is working okay. Everyone can hear and see the slides. And thank you everyone for joining, and also big thanks to the Menzies Youth Type 2 team for the invitation to talk today on screening and management of youth type 2 diabetes. Just to review what we have covered in this webinar series to date, and these are uploaded on the Diabetes Across the Life Course Northern Australia Partnership website. Dr. Angela covered what youth onset type 2 diabetes is and why there's concern around this condition. And a fortnight ago, Liz Watkins gave an excellent overview of some of the strategies on how to talk to young people and their families about type 2 diabetes. Throughout this talk, I'll be referring to these guidelines that were published in the Medical Journal of Australia in 2020. And although there's no consensus definition on what age youth onset type 2 diabetes refers to, for the purposes of this talk, I'm referring to children and adolescents up to the age of 18. And the next topic in the webinar series will cover young adulthood from those 18 years and above. So first on to screening. So although there's no data yet in paediatrics that early diagnosis improves type 2 diabetes outcomes, data from adults has shown that lifestyle interventions can delay or even prevent the onset of type 2 diabetes. And generalised screening of obese youth is at this point felt unlikely to be cost effective. But we know from prevalent studies and from our clinical experience that there's clear variation in type 2 diabetes risk between populations as well as regional differences. And so at this point, the recommendations from a number of groups is to screen high-risk individuals. Sorry, this screening flow chart's directly from the 2020 MJA guidelines, and I'll go through the features of this in the next couple of slides. So firstly, who to screen. This flow chart specifically refers to Indigenous children from Australia and New Zealand, so that is Aboriginal and or Torres Strait Islander children, Maori or Pacifica children. And the recommendation is that from the age of 10 or from the onset of puberty, which in girls is usually around at youngest 8 and boys 9, but has variation in age of onset, that screening is recommended in the presence of an additional risk factor. These risk factors are in the grey box here. So that is weight above the 85th centile on the BMI chart, which is according to age and sex, and or if the child's waist circumference measurement is more than half their height. Or if there's a maternal history of diabetes or gestational diabetes during the child's gestation, or if there's a first degree relative with type 2 diabetes, if there's clinical evidence of insulin resistance, which can be seen as acanthosis nigricans in the picture on the left, or if the child has other conditions that are associated with obesity or metabolic syndrome, which may include hypertension or high blood pressure, abnormal cholesterol lipid profile, fatty liver disease, or polycystic ovarian syndrome features, or if the child's on an atypical antipsychotic, which is known to increase weight. So essentially a high risk population in terms of ethnic background and age above 10 or at the start of puberty, and any one of those risk factors in the grey box. So how is screening recommended to be done? Point of care HbA1c is specifically used in this guideline because it's feasible in many primary care settings and provides an immediate result. And other screening methods may require more resources, may take some time for the results to return, and just add to the complexities of following up patients in this setting. It's important that point of care HbA1c should be interpreted with caution, particularly in the setting of conditions which affect the lifespan of the red blood cell, such as sickle cell anemia or moderate to severe anemia. And it's important that if diabetes is diagnosed on a point of care HbA1c, that a second test is used to confirm the diagnosis with either a laboratory HbA1c with a method that's certified and standardized, or oral glucose tolerance test or laboratory glucose measurements. What is not addressed in this flow chart, and what really we all need to put further attention into, is how primary care clinics can implement effective screening and how they can then provide appropriate management plans, including allied health intervention. So depending on the HbA1c result, there are 3 outcomes. In the green box, the HbA1c below 5.7% for this group suggests no diabetes, and an annual HbA1c is recommended. In the yellow, HbA1c in this kind of pre-diabetes area with a HbA1c between 5.7 and 6.4% may indicate impaired fasting glucose or impaired glucose tolerance, and may require lifestyle intervention, consideration of metformin, and an earlier repeat HbA1c at 6 months. Although it's important to recognise that while in adults, pre-diabetes might identify those at high risk of progression to type 2 diabetes, kidney disease, or cardiovascular disease, pre-diabetes criteria is not being validated in youth. So glucose definitions that are outlined in the bottom left are not without its limitations. And it's also important to mention that we do see clinically a subset of young people who fit the criteria of pre-diabetes that then spontaneously remit without intervention after puberty, which reflects the physiological or inherent changes in insulin resistance during this stage of life. But it's still important to keep a close eye on these children. And then in the red, HbA1c above 6.5% is diagnostic of diabetes and requires formal confirmation with blood tests, complication comorbidity screening, and implementation of a management plan. So moving on to management, and it would be great if this was my only slide on the management of type 2 diabetes, but the fact that you're tuning into this talk means that you really do appreciate the real challenges of helping young people with type 2 diabetes. So the first thing after you've made a diagnosis of diabetes is to first exclude type 1 diabetes, which is an autoimmune form of diabetes and is represented by the pathophysiology is insulin deficiency. So it's an insulin dependent form of diabetes and a very different disease process than type 2 diabetes. And even though we are seeing more cases of type 2 diabetes among young people, type 1 diabetes is far more common in the general population and still does occur in Aboriginal and Torres Strait Islander young people. So one piece of the puzzle that we use to differentiate type 1 and type 2 diabetes is looking at blood ketones. And so if a child has a blood sugar above 15 millimoles per litre, they need to have a blood ketones measured that day. And if this is not available in your setting, a urine dipstick can be used to see if there's presence of urinary ketones. If ketones are present, type 1 diabetes should be presumed until proven otherwise and needs urgent attention that day. So a phone call to your local paediatrician or endocrinologist. And as part of that workup, diabetes autoantibodies, including GAD or glutamate acid dehydroxylase and IA2, insulinoma antigen 2, should be sent. And depending on your local availability, other type 1 antibodies, which include zinc transporter 8 or insulin antibody, can be considered. Paired glucose and C-peptide can help in some settings to differentiate diabetes type, but the results can be affected by high glucose states and may be more effective to measure after a period of glucose stability. So if ketones are not present and antibodies are negative, still do think closely and carefully about the diagnosis. There seems to be different phenotypes of type 2 diabetes, and patients aren't fitting necessarily in a textbook description. So MODY is one particular form of diabetes that we need to think about. MODY is maturity onset diabetes of the young, and it's a genetic form of diabetes. So should be considered if a child has a very strong family history of diabetes in 2 or more consecutive generations, or the clinical picture or the trajectory of their diabetes doesn't fit with type 2 diabetes. And the reason that MODY is important to consider is that some types of MODY, there's many different genetic types, some respond to particular medication that we wouldn't typically use in type 2 diabetes. And there's one form in particular that doesn't require medication. So really having a thorough understanding of what the diabetes diagnosis is can help. And even once you've made a diagnosis of type 2 diabetes, it is okay to change your mind as more information becomes available. And so, if you get more information about family history, or if they develop ketones and are looking more like they could fit type 1, that's okay to rethink the diagnosis. So due to the high rates of complications that we see in young people with type 2 diabetes, screening for comorbidities and diabetes complications is advised at diagnosis. And that includes other medical issues such as obstructive sleep apnea, lipid abnormalities, liver disease, polycystic ovarian syndrome. And each visit should also have an assessment of hypertension, weight measurements, as well as mental health checks and general health and wellbeing review. And I'll go through the HEADS acronym in the next slide. Where it's appropriate, contraception should be discussed in a sensitive and culturally appropriate way, ensuring rights to privacy where indicated. And this is particularly important when we're starting to think about the newer diabetes agents. These foundational aspects were very well covered by Liz in the recent webinar talk, but are critical components in managing young people with diabetes. It's important to recognise that the adolescent period is a really difficult time in anyone's life. particularly if you're living with a chronic disease. And young people often have competing and acute health needs, and that each region does have variable access to resources and staff. So firstly, communication is really important, and respecting and utilising the family's first language where possible, so that education can be delivered effectively. And Liz had some great strategies on how education can be delivered, and would strongly recommend you listen to her talk if you haven't already. Rapport and trust takes time to develop, but importantly, it can be broken in a sentence or a simple action. So be mindful in your interactions with families. The HEADS acronym is a framework used in adolescent medicine and helps you to develop an understanding of the child and the family's beliefs and values, and should be considered when you're developing a collaborative plan. And there's an upcoming webinar series on adolescent medicine, which will cover some of the strategies for working with this age group. It's important to know that just because a child is not attending the clinic doesn't mean they don't care or don't think about diabetes, and so it shouldn't stop your attempts to try and engage with the child in a way that's supportive, not overbearing. So right from the first meeting, try to identify the child's local cheerleaders and call them on to support the child through this time. This could be the local clinic nurse, a school teacher, a clinic driver, really anyone. And there is a need for a team approach to this condition where different sets of skills can come together, but acknowledging the huge issues that people have with access to staff working in particular settings, especially in remote settings. Health workers and health practitioners are key members of the team, and they really do have a huge wealth of knowledge. And we as health professionals also have a role in upskilling and educating health workers so that they can best support the family. And they are often in a really powerful position to make huge differences to young people's lives. In terms of glucose monitoring, it really depends on the level of intensity of the treatment regimen and whether glucose management is optimal or suboptimal. Continuous glucose monitoring sensors have not been evaluated in paediatric type 2 diabetes, but have shown benefit in adult populations. They should be offered, if available, for children on insulin, but are not currently subsidised. The target HbA1c is under 6.5% and is recommended due to the anticipated longer disease duration, the accelerated rate of developing complications, and the higher mortality rate compared with type 1 diabetes and adult onset type 2 diabetes. But this target should be achieved without causing undue hypoglycemia or treatment burden. I'm not going to delve into the nutritional strategies, as this will be covered in a future webinar series, but just to highlight that access and availability of nutrient-rich foods, as well as addressing chronic eating behaviours within a family or a community setting, is really very complex. It's more than asking someone to eat vegetables. It's a society approach. For many young people, consumption of sugar sweetened beverages needs to be addressed, but as Samaria Corpus mentioned at the first webinar, that approaching this in small steps is often more effective than having huge goals that can be really quite overwhelming. Physical activity, sedentary behaviour, screen time, sleep, they're all linked, and there are recommendations on targets, but it's difficult for young people to achieve this on their own if they don't have the support from family or peer groups to make these behavioural changes. So this is the initial management flowchart from the MJ guidelines, which provides some guidance on newly diagnosed type 2 diabetes cases. The important aspects to note are that metformin should be started after an acute illness has improved if renal function is normal, kidney function is normal. And as with adults, up titrating slowly due to gastrointestinal side effects. Generally, extended release versions are better tolerated than immediate release, but some children do prefer the immediate release version because they can crush the tablets. Basal insulin is indicated if a child has metabolic decompensation, such as diabetic ketoacidosis or hyperosmolar hyperglycemia state, or if they're on maximum metformin and their HbA1c is above 8.5%. It is important to review glucose levels regularly after commencing insulin therapy to titrate and wean as quickly as possible. And the goal is to maintain glucose levels with the lowest dose of insulin possible to avoid promotion of weight gain. Bolus insulin with main meals is maybe required, but in my experience, it's really rarely adhered to. So consideration of other mixed insulins or ultra long acting insulins, do have their place for particular patients depending on their lifestyle. The Today study is a multi-ethnic cohort of approximately 700 young people with type 2 diabetes, and they received different treatments. So one arm was metformin, one was metformin and lifestyle education and intervention, and one was metformin and rosiglitazone, another diabetes agent. It's no longer used. And importantly, in this cohort, almost half the participants experienced a loss of glycemic control within 12 months. And unfortunately, lifestyle intervention plus metformin was not significantly better than metformin alone. And this was in a clinical trial setting where the average HbA1c was 6% with engaged participants because they were part of a clinical trial. And following loss of glucose control, introduction of insulin unfortunately didn't improve HbA1c, and that wasn't due to non-adherence. So it's really important that we avoid any blame or judgments, because even in a clinical trial where lifestyle intervention was included in one of the arms, it wasn't deemed any more superior than metformin alone, but obviously is important in terms of general health education and well-being. So long term, we know that HbA1c target is under 6.5%. If this is not achieved, reviewing the foundations that I mentioned before and ensuring that diabetes education's taken place, or re-education, checking the family's understanding, looking at child's well-being in their social environment and who the key players or support players are for the child. Often the answer does lie in these foundational aspects that are quite challenging to improve. But we are now understanding the role of some of the adult diabetes agents within the youth setting. So this is an evolving space to work in at the moment. More recent trials have been published only in the last couple of months. So I think it's all important that we recognise that practices may change over the next couple of years. And I guess the concern that we've all had really recently is that we're faced with a lack of evidence-based treatment to prevent beta cell failure, simultaneously knowing the staggering long-term health risks for our patients if glycemic control cannot be maintained. So in terms of other medications, the most evidence that we have to date in the youth type 2 space is with GLP-1 agonists, which have a range of mechanistic effects. And essentially they increase postprandial or post-meal insulin and reduce glucagon secretion. They delay stomach emptying, reduce liver glucose output, and it can induce weight loss through suppression of appetite centres in the brain. The most common side effects are gastrointestinal, including nausea, vomiting, diarrhea, constipation, and it's important that children and their families are aware of this. And if the medication device allows that, a slow up titration and dose might make the medication more tolerable. Large meals and high fat meals also slow the stomach emptying, and so if children are on these medications and they're still having large portions and high fat meals, then their symptoms of nausea and vomiting can be much more severe. So it's important to let patients know that. And in terms of constipation, avoiding constipation, drinking water, staying active, eating high fiber foods can help. Children do need to know about the risk of pancreatitis if there is unexplained tummy pain or vomiting, and the current recommendations to avoid in pregnancy and breastfeeding. In terms of weekly GLP-1 agonists, which makes sense in terms of really trying to reduce the treatment burden. Dulaglutide is available in Australia on PBS, which does not have an age cutoff. So as long as the PBS criteria is fulfilled, children can access on PBS. There was a recent clinical trial of looking at dulaglutide in 2 doses, 0.75 milligrams per week and 1.5 milligrams per week, compared with placebo, which was metformin or lifestyle, and or insulin. And it was shown that it was safe and effective. So there was a difference in HbA1c after 26 weeks between the placebo group and pooled dulaglutide group of 1.4%. Dulaglutide was not superior to placebo when looking at BMI, but this may be a dose-related effect. The other medication available on the PBS is semaglutide. There's been no published paediatric studies to date. In terms of other medication, long-acting exenatide has been approved in America for type 2, but it's not available in Australia. And then twice-daily exenatide is available, and liraglutide as a daily medication, but considering the treatment burden is important for this group. There was a previous study on liraglutide in 2019 that did show an improvement in HbA1c at 26 weeks and a trend towards improved BMI. But these studies in youth are small numbers, about 130 patients. And in this particular study of liraglutide, only half the participants reached the achieved dose of 1.8 milligrams. SGLT2 inhibitors are used commonly now in adults and block the reabsorption of glucose mainly in the proximal convoluted tubule of the kidney, resulting in increased glucose loss through the kidneys. The main side effects to warn children and families are the risk of dehydration, as well as DKA or diabetic ketoacidosis, which may present with without high blood sugar, so euglycemic DKA, that can present particularly in the setting of acute illness or fasting or around surgery. So really making sure that families understand that they need to measure blood ketones if they're unwell or if they've got gut symptoms, even if their glucose levels aren't high. In adults, there's been some concern about urinary or genital infections, so hygiene practices should be discussed. And it's unclear at this point whether there is an association with peripheral amputation or increased fracture risk that's been investigated in adults. There's only been one study that was published a few months ago in Paediatric type 2 to date, and it was shown that it was, SGLT2 dapagliflozin was safe and effective. And in those who adhered to the medication as part of the protocol, so the per protocol group, there was an improvement in HbA1c up to 0.5%, whereas those in placebo increased their HbA1c. And there was no episodes of euglycemic DKA, but again, these paediatric studies are very small. There was about 70 children on this study, and really short-term outcomes were looked at over 20, over up to 30 weeks. In terms of other agents, bariatric surgery has excellent results in terms of glucose and weight lowering compared to medical therapy. Here shown on the red in the bottom, HbA1c, looking at medical therapy compared with bariatric in the blue. But it's very complex to perform bariatric surgery, and the follow-up is also quite intensive. We don't have it available in Queensland, so it's not a readily accessible option. DPP-4 inhibitors are used in occasionally in adults, but to date the youth data is underwhelming. And in the future, I expect that we'll see more studies using GLP-1 receptor agonists and SGLT2 inhibitors at different doses, and potential combined GLP-1 receptor agonists that have shown some recent promising data in adult type 2 diabetes. So when considering all these new options, there's no approach that fits everyone, and it really does need to be individualized depending on a number of patient, family, community factors listed here. And I don't think it's unreasonable to call your local paediatrician if they have expertise in type 2, or local paediatric endocrinologist to run cases when you're considering newer agents, and particularly if you have a child that's under 14. So the key messages I wanted to convey, we know that youth type 2 is a rapidly progressive condition, earlier time to complications, targeted screening for Aboriginal, Torres Strait Islander, Māori and Pacifica children is recommended. Be open to reviewing the diagnosis of type 2 diabetes if things aren't fitting. Really focus on the foundations. They're difficult really to and quite need quite a lot of support to try and change, but small tweaks for children can have great outcomes. And really children and adolescents need a support person who's on their team to help them achieve positive outcomes. The approach needs to be family-centered. Additional medication, it's exciting that these agents, we're getting more evidence to use them, but they do need careful consideration. And insulin, in this setting does have, still a role, particularly when we're looking at children who have high HbA1c. These agents aren't going to resolve the HbA1c when it's sitting in the double digits. And just, I guess the difference between this population and adult, what we're, you might be more used to managing with type 2 diabetes, is that the adolescent stage is tough and has its own intrinsic considerations when we're looking at management. Thanks.
Thanks very much, Emily. That kind of wide-ranging discussion of all the different considerations in management. And I now welcome Raymond, if you could put on your video as well, to join the discussion, and people reminded to please post any questions. And Raymond will also be able to provide perspective from working in remote community and local Borroloola man as well. And just a congratulations to Raymond. I know he's a finalist in the NT Aboriginal and Torres Strait Islander Health Practitioner Awards, and so that is a great recognition of his work as well. I just the first question that I'll put to both of you is how is it best to monitor, oops, sorry, I've just lost the question. How's it best to monitor ongoing overall glycemic management if anemia exists, given a HbA1c may be inaccurate and CGM not accessible? Emily, did you want to?
Yeah, so that's a really great question. I guess mild anemia, from my understanding, doesn't, have a huge impact on HbA1c, but it's the moderate to severe anemia that can affect HbA1c. And there are, I think, in certain situations when there's hemoglobinopathies of fructose, forgotten the name, but there is another measurement that you could use. I guess it depends on the context of what's causing the anemia and if that is acute and going to be, treated and managed, and in which case I would still use HbA1c. But yeah, do you have any other thoughts on that, Angela?
Yeah, I don't see it as causing much of an issue in practice. You'd have to have a very severe prolonged anemia, and it doesn't clinically affect HbA1c greatly. What it would be if in like neonatal diabetes, for instance, you can't use HbA1c because you have fetal hemoglobin, which is not, so the HbA1c will be very inaccurate in that kind of setting, but not in youth onset type 2. So I might actually address the next question to Raymond. And sorry, Margie, yes, your question was first, but someone upvoted someone else's question, which is why I asked the other question first. So Margie has asked, when you say it's not cost effective to screen all kids, she's had feedback from one primary healthcare centre that using a screening tool is time consuming. It is easier and quicker screening all kids over 10 years. Raymond, do you want to comment on how you find screening or determining who gets screened?
Yeah, hi. The main sort of children we focus on is mainly the kids with high BMIs, or they're at that risk of having diabetes because of family, genetics and whatnot, but also the acanthosis that you can normally see on children and that. But yeah, that's the main thing where I sort of focus on, just the larger BMI kids, but also the ones that might have the genetics that sort of can, sort of pop out to me, and then we just screen those guys. Yeah.
So basically you're using the screening, the risk factors that are kind of in the screening guidelines. And how do you think it would go if you were just screening everyone? I think that's what Margie she was wondering, do we just screen everyone or do we screen by risk factors like you're already doing?
Risk factors, mate, like the time consuming just to try and screen every kid. But also, doing just BGL finger pricks and that. No kids will come back to the clinic. They're already petrified of, getting jabbed like when they come here. Yeah.
This question's both to you and Emily. It kind of, I'm going to it because it relates to screening. Someone's asked, what is your approach to discussing screening of young people and their families? So I suppose it's like, what do you say, Raymond, when you've got someone that has those risk factors and you wanting to screen them? How do you explain that to families?
Well, as you know, diabetes is such a complicated thing to, explain to someone that's got no, understanding or no sort of medical background about the body and the anatomy and physiology of, the body, how it functions and that. So explaining it to families and that is a major sort of challenge in itself. But that's a hard one. I just sort of.
how do people take it when you say that you're wanting to screen them?
Yeah, it's all right, but the most challenging thing is the engagement for me and building relationships with them and their families, because most of the kids are so hard to engage and they just sit quiet. But explaining that I want to, do some tests and that, and they might be at risk of getting diabetes, but then you got to go down the path of explaining what diabetes is and so forth. So when explaining diabetes, I sort of use terms where I butcher, sorry, I better not say that, but when I use like a human anatomy to animal anatomy that most Indigenous people around here when they eat. So if I talk about the pancreas, I'll explain it, when you get a killer of that, the pancreas is, the sweetbread. So, and that's what people sort of understand, and then go down the path of explaining, how the pancreas works. But then going back to screening, then encouraging them for, getting blood tests or whatever. Yeah. Hope that sort of half explained it.
I guess just on the screening question as well about, some kids just, as Raymond was alluding to, really don't want to have a finger prick, and that can be really off-putting for some kids. And so I guess just having, a discussion with the family and the child, if that's something they want to have. I think, those that fit the risk factors, we would recommend that. But if we were doing kind of global screening, I think it would be hard to encourage people who didn't fit the risk factors to have a finger prick if it's quite distressing for them. Even screening for anemia can be quite upsetting for some kids.
And I suppose, Emily, can you comment at all on evidence or otherwise of universal screening versus high-risk screening?
Yeah, there's been a couple of studies looking at universal. I think the only population where that was thought to be cost effective was in Japan when they are tested in schools, but probably, it reflects on the population risk. I'm not familiar with any screening studies that have looked at specifically Aboriginal Torres Strait Islander young people without the absence of risk factors. So I wouldn't be able to comment, but I think most children that we would see would have at least one of the other risk factors in that screening pathway. So it's really only a small proportion that don't fulfill that. Usually there would be clinical evidence of acanthosis or a family history in many young Aboriginal Torres Strait Islander children.
And just repeating someone's comment, Linda's comment is that I think it's important not to over-medicalise or over-intervene. While we know that youth type 2 is increasing, we still need to screen with purpose and screen with consent. And I think, Belinda, that's what both Raymond and Emily are kind of saying, that we screen by risk factors, but I think that actually opens up a conversation about general health, like in general, not just about diabetes, and thinking about, how we optimise health. And as Emily said, most young people that we see, or nearly every young person I've seen, they have at least one of those risk factors. I haven't seen any young person diagnosed that doesn't have at least one of those risk factors. So just so there's a question that's been upvoted that I'll address to Raymond first. Is, do you think young adults with type 2 diabetes could be effective in mentoring younger children that are diagnosed, possibly in a group or community forum? I think you just, unmute thing.
Could you sort of break the question down again? Sorry.
Sorry, the question was, do you think young adults with type 2 diabetes could be effective in mentoring younger children that are diagnosed?
Maybe not, only because the younger ones are so hard to engage and explain diabetes and the screening process and the ongoing management. But the younger adults are much more understanding and sort of have more of a chance of changing, you know, their HbA1c. Yeah, so the younger ones are so much challenging out here anyways, to engage and get them on treatment and continue the ongoing care. Yeah.
And Emily, your thoughts?
I guess it depends on the young person and where they are in their kind of motivation to receive information and to make change, and how they take on information and who, you know, they would listen to. I don't think it's a bad idea. I think, you know, it's having a community and a peer support works really well for some young people, that knowing other people living with type diabetes can be reassuring and can provide some support. I guess what Raymond's referring to is the practicalities of matching up the appropriate people, particularly if communities are quite small. Yeah, but I think peer, you know, as a general concept, peer support groups have really worked quite well for some people.
And this question I'll direct to you, Emily. Is there any research on whether starting high doses of metformin so early in life contributes to renal decline later in life? Is there any evidence whether the longevity of using metformin would worsen kidney function?
Sorry, it just froze at the start, and I'm just trying to find the question.
It's any research whether starting high doses of metformin so early in life contributes to renal decline later in life?
That's an interesting question. I don't know if there's any research looking at, you know, the metformin dose and renal outcomes. Is there any evidence on whether longevity of using metformin would worsen kidney function? I don't think that that's, you know, I'm not aware of any studies that have looked at that specifically, and it may be quite tricky given the disease trajectory and progression of renal impairment with type 2 diabetes. But that's an interesting question, whether metformin plays a role. I guess, you know, in the Today study, certainly all groups were on metformin. That has been a standard treatment, and there's been one RCT that looked at metformin versus no metformin in the late 90s, and that's really all. We've continued metformin since then, because it did show improved glucose outcomes. But yeah, I haven't heard of any specific association with renal outcomes. Unless you have, Angela?
No, I haven't. I suppose I just point out to whoever asked it, the renal complications of poor glycemia. So we know from Canadian data that 1 in 2 of young people with type 2 diabetes will have kind of end-stage renal failure at kind of 20 years. If the glycemia is not in target, compared to we just don't get those complications in type 1 diabetes. So just being aware of the risk of renal complications from chronic hypoglycemia, I think would far outweigh the risk of renal complication from metformin use. Sorry, just looking at the questions. I address this to you, Raymond. That it is going to be addressed in a whole session later in the webinar series, but someone has asked, does the school have any place in all of this?
My personal opinion, I think that schools should do more health education and focus on diabetes. There should be subjects that's, you know, taught around health and providing the education around diabetes and the risk and complications you get from it without, you know, controlling it. Yeah.
Emily, did you want to add anything?
Yeah, I think schools are a great resource, and I agree completely with Raymond that health education should be part of the curriculum, and potentially, it will be, I think, discussed further in the Models of Care webinar talk, but in how we incorporate schools into, say, screening and educating nurses and teachers about diabetes, so they can support young people who are attending school.
The next question addressed to Emily is, does bariatric surgery improve blood glucose levels due to decreased BMI, or is it due to reduced food intake and change in body fat that affects blood glucose levels rather than body weight BMI per se? So it's the mechanism of how bariatric surgery may improve glycemia.
It's possibly both. I don't know specifically, but I think it's probably both mechanisms in that reduced BMI from either reduced food intake or reduced appetite that may improve glucose outcomes. I don't know if you could differentiate both, because the weight outcomes are so so striking after bariatric surgery. I think it's probably a mix of both. The weight, that weight loss does improve your glucose control following bariatric surgery.
And I suppose the next questions are kind of linked as well to think about newer treatment agents. Someone's asked, how do the newer treatment agents affect contraceptives?
Yeah, I think it's just that it hasn't really been tested and examined in clinical trials at this stage. I don't know that there's any evidence on what happens from a placental transfer, but potentially one of the adult endocrinologists who has more familiarity using those agents knows more. But yeah, at the moment, it's that we haven't got that information available.
And someone has just put a comment. It's just asking if we could please provide the reference for the use of off-label agents in paediatrics.
Yes, I put it in a chat, but I think it can only be seen to the hosts and panelists. But it was from Amy Shah.
Maybe just add it to the questions and answers set.
Part,
and then everyone will be able to see it. Yeah.
Yep, no worries.
And this is a question, I suppose, for both of you about screening. Someone's asked, if diabetes screening is conducted, are the risks of eating disorder or disordered eating screened? I suppose I'll just add an extra question. Do you see many young people that have disordered eating or eating disorders that you think are at risk of diabetes?
Yeah, mate, most of the kids I see around here, I'll get them in, do some education information on healthy diet and, changing it. Instead of drinking a soft drink, a can of Coke, maybe change it to Coke Zero, just simple little things like that. But then go down the shop and then I still see them, buying lollies and chips and other soft drinks and that. So, yeah, it's a bit hard.
Do you see many young people, Raymond, that you think are like binge eating or have restrictive eating?
Yeah, mate. Yeah. I've seen some kids, like, they'll have breakfast at home and then they do a breakfast program at school, and then like I'll see them there eating as well, and then they're always at the shop. Yeah, such a hard one.
Yeah, I agree with Raymond that there's, certainly eating behaviours a significant influence, I guess, on what's happening in terms of development of type 2 diabetes, that a lot of young people do have disordered eating in terms of binge eating. That's really quite difficult to help manage.
And I suppose, can I just do a follow-up question to both of you about What do you think about food security for these kids?
I think with the major thing with Indigenous people, especially out here, is housing. You know, you got so many people living in the house, and food security is right there up on top. So, you know, most people around here don't really buy, you know, vegetables, you know, healthy things. So they buy things so easily, things that are easy to hide, if you know what I mean, like a tin beef, instead of buying a steak out here. So buying a steak would only feed one person. Buying a can of tin beef is the same price, but can feed, I don't know, 6 people out of the one tin. So yeah.
And Emily?
I guess I mainly work in Southeast Queensland, but when I have worked remote, food security is massive in terms of access and price, as Raymond alluded to, and convenience is what I see really in Southeast Queensland, that it's a convenience to quick food and not having skills to cook. Or a motivation to cook, and having, I guess, access to different foods that are more convenient or cheaper is, you know, spans both across regional, remote and urban settings, but is a huge factor in why these particular families may be more at risk.
Just going on from that, I'm just looking at another question that someone's posted. It's for both of you. It's how much of these eating and food access behaviours do you think are generational? Is it still better to direct most of the education to the family members? Is role modelling still more effective, or should we try something else?
Yeah, it's a good question. I think, you know, from a child's perspective, it needs to be a family approach, because they're not the ones buying the groceries. They're not the ones who, you know, ordinarily would cook, but, you know, it would be great to teach a young person to be able to do the shopping and do the cooking. But often that's not realistic for health clinics to be able to provide that opportunity to a child. And so the child is reflecting the setting and environment that they're living in. It's really tricky, because often, even if a child is motivated, the family is still the ones that are bringing home food or making decisions about what type of food is eaten in the household. I don't think there's a clear answer, but just, you know, trying to target a family member as a support is, you know, obviously going to be helpful from a child's perspective, but it's not often possible.
And Raymond?
Yeah, mate. So yeah, it goes back to both parents. You can talk to kids about, you know, healthier eating and lifestyle changes, but it's the parents that's doing the same thing. You know, they've also got diabetes. Well, the ones I deal with out here. So you're talking to a child about eating healthy, and then you got the parents saying, "Oh, yeah, well, I'm going to stop buying you all this, and this," but they continue eating the way they, you know, eating bad. So it needs to be a more family and group approach on maybe changing the lifestyle or the way they're eating and that, and sort of focus on trying to change that. But yeah, it's so hard. So I just try and tell them, instead of going in and buy, you know, a can of Coke and a pie, which is so easy, instead of buying a can of Coke and a pie, maybe buy a bottle of water and a sandwich one day. You know, try and do that maybe once, twice, or maybe 3 times a week, just to try and encourage that better nutrition and diet. Yeah.
I think that's a good point that will come back up in a later webinar about nutritional strategies, because I think you mentioned it before, Raymond, that these young people, they might have high BMI, but their nutrition is lacking. So they're actually not nutritionally balanced, even though they have high weight or a large amount of adiposity. Yeah. Thank you both so much for your discussion today. It's been really excellent to be able to listen and learn from both of you. Just a reminder to everyone about the next session, which will be on Thursday, the 15th of September at the same time. It's going to be, and the presentation will be by Dr. Matt Hare. He's an adult endocrinologist at Royal Darwin Hospital, and the topic is about management of type 2 diabetes in the young adult age group rather than the paediatric age group. And the co-presenter will be Samara Corpus, who is a diabetes educator at Royal Darwin Hospital for the discussion. And a reminder that if there's cases that you would like discussed, please actually email them through to us. We'll send them to the presenters and co-leads so that they could bring out some elements and have case-based discussion. And thank you very much. And remember also that there is feedback survey. So if you could take a few minutes to do the Survey Monkey, that'd be great, so that we can guide the content and kind of the structure of the rest of the webinar series. But thanks so much, Emily and Raymond.
Thank you. Thanks, everyone.
Thank you for having us.